All right, so going to go through this. We have some time for a case. This I added, and this is just, we can discuss this also. This is a 12-year-old female Hispanic. She was in the 7th grade. It's kind of hard to read, so I'll read it. Got it in a different order. Biological mother is deceased. Her biological father has a history of incarceration, but he was able to follow all the guidelines in order to regain primary custody of client. Client has 3 older sisters that live apart and have their own families. What are some other significant relationships? She has 1 school friend, but stepmother has some concerns about this friend. Who does she live with? She lives with bio father and stepmother. Some of the cultural issues, father only speaks Spanish, and that led to some difficulty with school. And that's too small, so I'm going to read it from here. So client discovered mother's body after a violent death. So preceding the death of mother, client was placed in foster care until bio father regained custody, until client reported that he was wrongfully accused of domestic violence events with his current girlfriend at the time. Client then was taken from father, placed with the maternal grandmother, where client reported physical abuse by maternal grandmother. The client presented with inconsistent sleeping patterns and nightmares, self-harming, and isolation from family. So we did a TSCC for the physical abuse, and she scored clinically significant in the range of anxiety, depression, PTS, and a possible problem with disassociation. We did a gift. She scored normal range for separation distress, but clinically significant in maladaptive scores for existential identity distress. Now, the existential identity distress, that is when they're trying to figure out, who am I without this person? Who am I without my mom? Now that my mom's not here, I've been abused physically, I've been in foster care, this is all happening, so who am I? And then she clinically significant for circumstance-related distress. And that was mainly related to the circumstance of finding mom's body. And then with the PTSD reaction index score of a 13. And the normal range for that was a 2. So she had some serious PTSD. Now I'll go back to the other one. Right off the bat, what do you think that I was dealing with this 12-year-old? What? Yeah. There was multiple traumas. Very complex. What are some of the other things? Multiple losses. Because it wasn't only mom, it was dad. And she said he was wrongfully accused at the time he was living with a woman who was physically abusing her. But she reported domestic violence with bio father, and he ended up being incarcerated. Anything else? So I'll go back to this one. So where am I at? Right now we're working with cognitive coping with her. We're doing the triangle. We are trying to connect all of those thoughts, feelings, and behaviors. She is learning how to utilize expressive arts. She started writing her own poetry and using music as one of her coping skills. It says, briefly summarize the caregiver's involvement, because again, engagement with caregiver is so important in this model. Both caregivers were consistent. They were committed to weekly sessions, practicing the breathing techniques at home, and engaged in holding space for that client, sharing the feelings. So what do you feel has gone well with this case? The client has taken to expression through art, music, and poetry. What factors, if any, do you feel disrupted treatment process? During the time of treatment, client was removed, not removed, but they had to move from one home to another for other reasons. So she had to leave her school. So she's going through treatment, and then guess what? They have to leave their home and they have to move across town. So that means a new school. Go on to the next one. I'll do a timeline. So timeline, I'll read this. Age 5, witnessed domestic violence with older sister boyfriends. Age 7, parent separation, bio-parent separation. Age 8, witnessed domestic violence with mother's current boyfriend. Age 9, she discovered mother's body after what appeared to be a violent death by evidence of gunshot entries. Age 9, lived with bio-father and stepmother where client reported physical and emotional abuse by stepmother. Father was then accused and found guilty of domestic violence event reported by stepmother. Age 10, client placed with maternal grandmother until client reported physical abuse and placed in foster care. Father released and began steps to gain primary custody of client. Age 11 and 12, father regained primary custody and client placed in father's care. Father and stepmother reported some symptomatic behaviors related to traumas and called the Center for Treatment. Using a timeline is really important in this model also because we can find out through this timeline, again, using this timeline with the client that I had talked to before where the sexual abuse was not her trauma, that's where I found when she was younger what her traumas were. They were bio-fathers, abandonment, and some other, but using this timeline in this model is really helpful for us because sometimes we have to park. When I call it park, it's like, okay, well, let's park that and go back to this because I'm following their lead. And it doesn't make any difference of what I think they should be processing because it's not about me. It's not about us. It's about what best suits the client and what's going to help the client. And the practice components. Engagement is always important. So I reported there was no barriers. The client was engaged once we found the right interventions. And for her, it was music, poetry. The assessments I did, TSCC and GIFT, psychoeducation was ongoing in regards to the self-harming and then the symptoms of abuse. Parenting, both stepmother and father were fully engaged and committed to clients' treatment sessions and practicing learned coping skills at home. The relaxation, what she enjoyed was the 4-7-8, and she brought her calming jar at every session. Affect regulation, client's favorite tool was throwing emoji ball before session. So she's like, oh, let's do the emoji ball. So that was something that she connected with. Cognitive coping, client introduced to the CBT triangle, identified cognitive distortions. And that's where we ended. I mean, that's where we're at right now. The in vivo is just continued using the difficult words again. In vivo is using those words and trying to desensitize those really traumatic words for them. They're not ready to say things, but we can help by saying the words that they're not ready until they are. Any questions on this? Yes, sir.
I have a different question. How do you deal with the horrific situations that you deal with? Because they're all kind of intense in the same kind of area.
That's a good question. We do a lot of compartmentalizing, and in trauma training, we have to be, as the counselor, as the therapist, we have to be comfortable with the uncomfortable. And working with children with sexual abuse, I have to be comfortable with words that I don't like. And so in the training and ongoing is in vivo for myself. Because I will have a 6-year-old come and say, well, so-and-so put his you-know-what in, but he will say the word. And I can't say, wow, this 6-year-old is using the D word. No, it's like, okay. So we have to learn how to be comfortable being uncomfortable and hearing those words. So what are some words that we're uncomfortable with? A lot of sexual words that I'm uncomfortable with, but I can't be that in session. Or when they start talking about the physical abuse, it's the same thing. Does that help?
You do, the different therapists, did you do self-care together? Like debrief, self-care?
We do. Every week we have consultation and then we have program meetings, and that's really important. And I am the trauma therapist there, so I get a lot of difficult cases. My cases are usually CPS. A lot of my cases have been through here. I have to be very careful with identifying factors here because a lot of my kiddos are back and forth here and into my treatment. But for the most part, they understand that my cases are a little bit more different than the natural bereavement. I think I'm almost done. So, I'm sorry.
Dealing with childhood trauma, does any of the kids ever develop like DID later in life?
That is really important for us to keep assessing, and that's why we try and give them the tools now. When we're in treatment, we do our assessments every 90 days, and hopefully they won't. But with such severe trauma, if it's untreated, then that is something, like I said, that's one of the identifying factors in our assessment because of the trauma is so severe. So hopefully we are trying to process that trauma for them so they can grieve in that natural way so it doesn't get to that. So things to remember. The child with CTG is stuck in the trauma, and that interferes with the natural mourning process. Our job is to get them unstuck. Clinicians assist in helping children and caregivers process the trauma in order for them to continue to heal and mourn naturally. We can only do so much every week. We have to rely on the caregivers to facilitate that healing, and then again when they're no longer in therapy. Do y'all have any other questions? I have some really good resources on there also. There's a TG-CBT, and that's the web course, and you can get CEUs for that, and that's free. And that should be on your sheets. There's also the CTG. You can also get CEUs for that, and that's all connected. And I put the YouTube link, so the Just Breathe, that's always really good to have for the kids. And then, of course, the National Child Traumatic Stress Network. That's where you can get a lot of the handouts that I use. And that's all I have. Thank you so much.